So I'll go to one of my other ECIST colleagues, Kate Pound. So Kate was, and I was as well, one of the many participants from across NHS England and NHS Improvement that supported both the programmes, and we heard many stories speaking to people who wish to return to both healthcare support worker roles and to nursing roles. So Kate's going to share some of those stories with us now. So over to you, Kate.
Hello everyone, thank you very much for the time today to share these stories. So I mean, I was really touched to be involved in this work. I mean, what was clear to me was the compassion and the energy from people to really, you know, they wanted to be there at the front line no matter what the risk was, to support our staff with caring for those with COVID or caring for anybody that was in need. And some of the stories that really resonated with me was, I remember speaking to one person and, you know, his reason why he wanted to get involved was, you know, his sister had died. And what better thing could he do than to roll his sleeves up and get involved? And that really touched me, the compassion and the empathy that came from these people. And, you know, the other thing that was really important was their experience and their skills. So there was one person that really stands out with me. She was quite a young person, you know, in her early 20s. And she had such a breadth of experience. You know, she'd been working in the community, looking after patients on ventilators, which were being cared for at home, and the breadth of her experience and her knowledge. But yet, the famous line we kept on hearing from people was it was really hard to get to work in the NHS. So those were some of the messages, and you know, that we've just talked about our feedback and feedback loop. But it was just phenomenal. These people were there with great skills and wanted to come and help. And then I was going to say the third group that really blew my mind away was the cabin crew. And I know when I first heard about, you know, we're going to be looking at cabin crew, I was kind of like, really? How cabin, you know, what is the transferable skills? But then when I actually started to learn about the fact that this group of staff have advanced skills in, you know, they can deliver a baby and deal with all sorts of medical emergencies. And then when I started interviewing the cabin crew, oh my goodness, they were just amazing. And they were going through such a difficult time for themselves. You know, they were told you can't work. You know, there was risks of redundancy. You know, they were going through really difficult times. And to be able to help them see a future, and that future was in the NHS, in our family, was absolutely amazing. And, you know, some of the stories they told me, and, you know, I think about what, as a nurse, I've had to deal with on the wards, but their stories were like, you know, dealing with cardiac arrest mid-air and then having to do CPR as planes are coming into land, or having to deal with a death in flight, and you've got the family, you've got distressed passengers, you've got all sorts of things going on around you. And it soon became evident that this was a group of staff that certainly had skills that could support the NHS and become part of our family.
That's great. Thanks, Kate. Are we able to go over back to Richard now?
Yes. Richard, are you there? Oh, he's just rejoined. Hang on. Okay. Any moment. Hello, Richard.
Just while we're doing that, do you want to tell us a bit more about your experiences? I know, you know, an experience of how ECIST got involved in the programme, and I know some of the things that Richard may have been talking about was how how the programme developed over time, and you know, sometimes you're building the aeroplane as you go along. Do you want to just touch on that a little bit?
Yeah, so as I mentioned, I was one of the ECIST staff, just a small group of the wider group of staff from across NHS EI that responded to the call around this. And one of the things about this was it was an improvement journey. I think Paul touched on it. And you've just mentioned that, Nick. We were building the aircraft as we went along, and we did learn a lot. The daily huddles, we had huddles for the nursing element, just the same as they did for the healthcare support worker element. And actually, and I can't remember at what point in the program it was, but we actually joined the two daily huddles together. We tested things, so there were lots of tests of change going on, and we had a kind of quite a structure in terms of the way we sort of huddled every day, so we could pick up the learning. So you know, the nursing element was an improvement journey, just as the healthcare support worker element was.
Yeah, great. Well, I know we've spoken before about this, and some of the really interesting work that you picked up on, and just as Kate mentioned, the amount of people who wanted to come back, either to yourself or to Paul. What were the kind of numbers that you saw in the end of both nursing and healthcare support workers that you saw coming forward, but also actually managed to get into nursing?
I'll let Paul pick the health. I don't know the numbers off the top of my head, but Paul might have an idea. And
I was going to say, I think also at this point as well, Nick, it would be important to add in that for many this was only their start of their journey, and being in touch with us meant that it supported other improvement work, and actually many of the ECIST team members actually became almost kind of like did career coaching with our people that we're being in touch with about how to get into the NHS, and what, you know, many of them are interested in becoming nurses. So and I think those are, you know, really important aspects that perhaps weren't necessarily anticipated at the beginning, but actually grew. I'm sure Vince would agree with me on that, and Paul.
That sounds like a really important point, isn't it? Where, you know, this was a route for people to come in as well if they had any kind of interest. But I think, as you touched on, there were people that just, and maybe touched on before, there was like a call to arms, wasn't there? There was a point where people felt, you know, if we thought about it before, this was the point where I'm going to do something about it. Is that something that?
Yeah.
Oh, Richard's back. Hi, Richard.
Hi, everybody. My apologies. Technology has befuddled me there, but I think I came in at an opportune moment talking about some of the numbers and some of the challenges. So, I mean, I think, so this began back on the 20th of March, and you may remember the NMC wrote out to a number of retired registrants and said, if you retired in the last 3 years, did you want to consider coming back as part of our COVID response? And it's fair to say the response was overwhelming, and I think that's both in terms of people's interest to come back and do that work, as well as people's interest, if you like, within teams to try and help make that happen. So there are 11,740 registrants that took the call to arms, which is a big number. And I guess if you spread that over the last 6 months, that may not seem quite as challenging. When you consider that 5,700 applicants applied within a week of that call to arms, there was an incredibly small 3 or 4 person team who was trying to do something called the Return to Nursing programme at the time. And I think that just gives a sense of scale around really the challenge and the positive benefit of all those people responding. I think that led to trying to very quickly mobilise an infrastructure that would manage that volume of people. And one of the things we learned very quickly was building as you go, trying to learn as quick as we can. And I know others have mentioned working together to kind of provide that very rapid feedback loop to learn and be doing things better the next day. I think one of the things we would recognise is that if we did that again, we've got a tried and tested method. We know, broadly speaking, how long things take to do. We know what kind of resource we need behind it. So we've learned about how to set up something at that scale and magnitude. I guess we maybe didn't expect that volume of people in such a short period of time. And you may remember Ruth May, the chief nurse, on BBC News. And you can see very clearly, like you often can in an SPC chart, that correlation between that public call to arms and then the immediate volume of people received both in our email inbox and on our survey responses. So I think it's fair to say that, you know, it was an overwhelming response. But lots of positives in terms of people working together to create a solution. And most of the team acknowledge, and I know Kate talked about some of the personal stories, none of us, I think, can underestimate some of the sacrifices people wanted to make to come back and be useful and do things, as well as conversations we had with people who weren't able to come back but wanted to help, and experience frustration. So this process, I think, didn't respond at times as quickly as we might have liked. And you may remember that, I suppose, when we set it up, we were thinking that there was going to be an enormous requirement for all those nurses. And in some respects, it's positive nationally that that didn't happen. But I sense there are frustrations from people that pulled out all the stops to want to be back and doing things that may not have realised their ultimate goal. Partly because that's where we got to. The good bit now, I suppose, is we're left with a really positive story about nurses and people wanting to come back. And we've seen an improvement and an increase in the number of people that want to undertake return to practice OSCEs. So it was a very good marketing exercise in terms of being able to get people back into the profession. I think the other things we've learned, and is built on the National Recruitment Retention Programme learning, is that flexibility was really key. And lots of organisations began to offer flexibility to people. And the people we spoke to often had left the profession because of a lack of flexibility. So I think we need to hold on to things like that and really use those to try and help us to become more responsive and agile as we go forward, whether it's in or out of COVID.
Thanks, Richard. I think that's a sort of good lead-in. I'm going to give the final word of the session to Paul. So Richard's just talked about how the programme from the nursing perspective has shaped some of the thinking.
I don't know if Vince is coming back in.
So can you hear me?
Can I answer Tim's question? Because Tim's posted a question about, do we think it will have a positive effect? So I think I mentioned a couple of things about recruitment retention. It was certainly the biggest marketing campaign that we've ever seen. And when we've looked at the shortfalls in nurse staffing and a number of active campaigns, this had a significantly stronger effect as a national call to arms. But I think if you think about the type of people that work in healthcare, they're often people that want to be very giving of themselves and trying to put themselves forward to continue the good work and living those values that they've got.
Okay. Can you hear me? Not sure. If
yes,
you can hear me. Oh, right. Okay. So Richard's just spoken there about the impact of the programme on shaping the future of nurse recruitment. So I'm going to give the final word here now, the last few minutes of our session, over to Paul to talk about how the experience has shaped the recruitment of healthcare support workers. So back to you, Paul.
Thank you very much, Vince. Okay, yeah, so what we're doing now is we've now got a big, a major recruitment programme going for healthcare support workers, and that's healthcare support workers in every sector: mental health, acute, maternity, community, learning disabilities. We're aiming to recruit 20,000 healthcare support workers and looking at all the different avenues we can get into. So we are considering cabin crew, we are considering people going into schools and sort of educating people around how school leavers around how to come into the NHS. We've also looked at the care certificate and developed a fast track care certificate. So those that have got lots of experience in different sectors can undertake the care certificate and progress through that very quickly. We're looking at people who also have got degrees in other subjects, geography, history, whatever, and giving them healthcare support worker experience, putting them on the getting them to do the care certificate, and then fast tracking them through to getting them fast tracked through to RN training. So the program really has, the initial returners program has really helped us to shape this big recruitment drive for healthcare support workers, and looking at different avenues for people to come into the NHS and have it as a career for life. The other thing I think is also important, and Richard did touch upon this, and that is that those that are on the temporary register currently, we are having a big drive to encourage them to do the test of competency or the return to practice courses, so that they then can go back and rejoin the permanent register. So both the RN returners program that we did, and also the healthcare support workers program we did, has really helped us to shape these new programs to bring new people into the NHS, and also encourage those that have got experience to come back into the NHS, but also do it in a very structured way, a supportive way, so that people who do come into the NHS the very, very first time, they've got a clear career pathway. Thank you very much.
Thank you, Paul, and thank you to Richard and Kate as well. And as you've heard there, I think the both elements of the programme, as Paul has just said, not only responded to the initial call to arms, but have helped start to shape some of the thinking in terms of the future of recruitment for both healthcare support workers and nurses. So I think I'm passing back to Pete now.
Yeah, brilliant. Thanks, Vince. Thanks, Paul. Thanks, Kate. And thanks, Richard. We're going to go to our next session now. And my ECIST colleague, the fantastic Lisa Hume, is going to introduce Dr. Kat Noble. Over to you, Lisa. Are you there?
Thanks, Pete. I am here. Can I just do a sound check? Can you hear me?
We can hear you. Pip, if we can put Lisa and Kat's cameras on, that would be great.
Yeah, Lisa, you've been made a co-host. You as well, Kat. Oh, there we are. Success. We can see you.
Okay, can we just do a sound check for Kat? Are you there, Kat?
Yes, I am.
Lovely, thank you very much.
Perfect.
Okay, so welcome everybody, and thank you for inviting myself and Kat along to talk about all things 111 today. So I would just like to do a bit of an introduction to my colleague today, Dr. Kat Noble. So Kat is a GP specialist in emergency care, and she's worked clinically in GP, urgent care and emergency department settings now for 16 years. She first became involved in 111 back in 2009 when she was part of the County Durham and Darlington single point of access pilot for 111. She then became National Advisor for the Department of Health, going on to co-design the national assessment process for 111 providers with Dr. Nicholas Reeves. And then in 2012, she became the National Medical Director for NHS Direct, and in 2013, the Co-Medical Director for NHS Pathways. And now, while still working clinically, she holds roles as a CQC inspector, an ECIST clinical associate, and she's also the Associate Medical Director for 111 with North West Ambulance Service. So I think that totally qualifies Kat to talk about the subject matter today. So welcome, Kat.
Thank you very much.
We've got no slides today, guys. We're just going to jump straight in and start some discussion and debate. So do feel free to throw any questions in the chat box if you have any. So, Kat, I guess a great place to start today would be just to tell us a bit about the 111 service, really. If you could give us a brief history and in simplistic terms tell us what it's all about, that would be great.
Yes, of course. Well, thank you very much for inviting me. I guess, and the first thing to say is 111 land is pretty complex, is pretty complicated, and it's often a topic which generates a lot of opinion. So please do chip in terms of the chat box, and if there are any sort of, evidence out there from the first followers and so on, we'd really love to hear from you, because every day is a school day in 111. So in terms of history, 111 actually started back in 2007 with the Department of Health document, Our NHS, Our Future. And that was the document which said that non-urgent care should have a 3-digit single point of contact for everyone to be able to access. Ofcom then appointed the 111 number in December 2009, and in August 2010, that was when County Durham and Darlington, but also Nottingham and also Luton, were the first pilot sites, the single point of access sites, the precursor to 111. I guess by way of background, it's useful to know the 111 essentially sort of replaced NHS Direct largely. NHS Direct was fronted by nurses. It remains an outstanding brand. It amazes me. I still see documents, pamphlets around about hospitals which still quote NHS Direct. And the public sort of loved NHS Direct. However, demand was outstripping the capacity to be able to deliver that service. And so there was this kind of recognition that urgent care could no longer be fronted necessarily by clinicians, and demand needed to be soaked up in another way. And so that came to be that clinical decision support systems became part of our service. And essentially they were sifting and sorting demand, meant that they were supported systems, so they could largely, not always, but largely be fronted by non-clinicians. But of course, there is always an element of clinical support in the background. So the largest clinical decision support system is NHS Pathways. And just to finish off that history, it was Andrew Lansley's parting gift that in 2013 he landed 111. So all of England went live with 111. Difficult times, I think there was kind of strong clinical opinion about that being done unto us. And also slightly hampered by the fact that the communications budget within the Department of Health was pooled, and so there was no communications round about that that change to our service, which again made for tricky times. And I think actually 111 has struggled to regain ground from a brand point of view since. But of course it's now huge, and it's about to become even more huge, and it takes sort of in excess of sort of 5 million calls a year, so absolutely vast, and a vast potential for data and for health intelligence. So I think the 111 has obviously become kind of common parlance now, and with I think 111 first. And I think everyone kind of assumes that we know what 111 is, but I'm going to indulge and really kind of go back to real basics about what 111 is and what it isn't. Hopefully because that will help people understand, it will help people be able to understand where the blockers are in terms of their own systems that they may or may not be coming up against. And so essentially 111 is the telephone number, and that's all it is. But after you phone that telephone number, most often you encounter an IVR, so an interactive voice response. And that's where you get an element of choice, and that has developed since. So for instance, that IVR may include options to choose. If you're a healthcare professional, you want to speak to another healthcare professional, or if you're speaking about a dental, if you're phoning about a dental call, you can be routed straight through to dental practitioners, or indeed you could be assessed. Now, that isn't an element that there are various private companies that offer very sophisticated IVRs, which may be something to watch out for. After you get through the IVR, and if you are going to be assessed, then that's where the clinical decision support system comes in. And it's response driven, so that's why you want to speak to the person ideally and not a third party. It's not something that you can say, show me the pathway for back pain, because that doesn't exist in isolation. It depends on what the person has said before. It depends on the supporting information that the call taker introduces, etc. But the end point is you end up with an outcome, which is a mix of a symptom group and a symptom discriminator code. And that roughly tells you what clinician could meet that need, and roughly in what time frame you might need to see that clinician. It then passes to the DOS, the Directory of Service. And And this is where the SDs and SGs are matched. And this is a particularly critical part because that matching is local commissioner led, and it requires that that they detail their services in enough detail to be able to create the best options locally available for those patients. So, for instance, you know, if a DOS isn't updated that an urgent care centre closes at 8 p.m, then the system will carry on feeding people through to that service. And also the backstop is if the DOS can't match that call with anything, then your backstop is that call gets referred to ED. So that's your no returns. But of course, the service is supported by clinicians, either floor walking, actually, virtually, and that is a whole grade of workforce, which the NHS England produce a workforce deployment programme around. So that really, in essence, in a nutshell, it is the simplistic view of 111.
That's great, thank you, Kat. Can I just do another sound check there? Because I know I'm being advised that I've got video problems. Can people still hear me?
Lisa, we can see you and hear you now. Perfect.
Okay, great. Thank you. Thank you. Okay, thanks for that, Kat. That was a really useful history to get us all to the position. So, just in light of where we've been and now where we're going, the national agenda for 111 first. Can you tell us a bit about that, and then we'll come on to have a discussion around some of the published evidence that's out there.
Yeah, of course. So, everyone will be coming very au fait with the Think 111 First, which is a national ask. Essentially, the specification is kind of built round about a kind of a learning and a response sort of post-COVID. It does stress that the first point of contact for patients should either be their GP practice or 111 in obviously urgent but non-life-threatening situations. It talks about remote assessment, remote working, the use of technology, the reduction of travel to physical locations, particularly reducing or minimising the potential for overcrowding in EDs. It also talks about protecting the most vulnerable groups of patients and particularly mental health. And I'm sure, you know, as a clinician and all of you listening as clinicians will be slightly daunted at the wealth of mental health issues which are now creeping out post-COVID. It talks about 111 having the potential to directly book into services, including EDs. It also talks about local services doing the comms, the communications to the public behind this work, and also about sort of clinically validating all ED dispositions which are appropriate to validate. So there are first follower sites which are going, and I would love to hear from some more of those. And some of this talk builds on ECIST's team and the feedback and the vigorous discussions that we've had over 111 so far. However, the specification does say that all services need to deliver this by December, as in December this year.
That's great. Thanks for that, Kat. So we have got some questions in the chat box, but I think before we move to the questions, just around the published evidence that's out there, because as you say, we did a bit of a sense check with some of our colleagues within ECIST over the weekend, which generated some really interesting and healthy debate around all things 111 and certainly the 111 First agenda. So can you tell us just a little bit around published evidence, and then we'll pause there and try and answer some questions.
Yeah, okay. So for the published evidence, I'm going to reference Jen Lewis, who's part of Sue Mason's team from Shire, who produced a really chunky bit of evidence. They looked at 3 million 111 calls ranging from 2013 to 2017. Looked at ED attendances, the hospital admissions up to 7 days after the 111 calls. And just the very high level detail, although I've just heard back from Jen actually that they're about to publish something more, is that essentially in the service that they looked at, less than 10% of patients were told to go to ED. However, 23% of callers did. But the next bit for me is more interesting. Of those who attended ED, some of whom were told to, some of whom were not, they looked at the disposition that had been reached within 111, and it seemingly, regardless of disposition, so whether it was primary care right through to ED, roughly 30% of each of those groups ended up being admitted, which for me makes me question the clinical decision support system and the pace of evolution of it. I guess there is an argument that that data was from a sort of pre-CAS, pre-clinical assessment service era, and with integrated urgent care contracts and so on, things should be more joined up. Calls should be validated. However, I understand from NHS Digital colleagues that a similar bit of work was repeated in 2017-18 that found, excuse me, much the same thing. So I think very interesting evidence for us to factor in to think 111 first agenda.
Absolutely. Brilliant. Thank you for that, Kat. So I think we've got 5 minutes till the end, and I am aware there's a few questions. So Pete, could you advise us of the questions, please?
I can. So the first question is from Siobhan. We're interested in increasing direct bookings, but technical processes within 111 don't really support this easily. How do we move this forward?
Yeah, okay. You're speaking to a clinician, not to a techie sort. So might be limited in how I can respond to that. All I can, I suppose, say is that there are challenges with the technologies which interface between 111 services and hospitals and so on. There are also challenges, I guess, in terms of the buy-in of services to allow direct booking. Obviously, direct booking was first started into GP practices, and there was really quite a strong pushback for GP practices in allowing that. But actually, the evidence now is more that the appointments that are offered aren't actually used. So yes, I'm sure there are technological challenges about that. Offering it makes entire sense, because I think this is one of the problems in urgent and emergency care, is that we have lots of services involved, but no one actually takes proper responsibility for sorting out the next step in that patient's journey. And that's when patients circle around our system, I feel. So to be able to offer into appropriate services which are governed by local commissioners and kept up to date by local commissioners is utterly key to deliver an effective patient outcome.
Right. Thank you, Kat. Siobhan, I would just add into that as well. I'm not sure which region you are working within, but the Midlands NHS E&I regional team actually have an NHS Futures platform that has a 111 page as part of that platform. So I'm sure if you wanted to join that, it's got a really good discussion forum on. You could maybe post a question and link in with colleagues from the Midlands if you're outside of that area. Okay, I think we've got a couple of minutes left. So is there another question, Pete? I'm
going to pick one question. Apologies to Rob for not picking his, but this one's from Joe T. Do you think the phase 1 asked for the 111 rollout by December the 1st will achieve change in emergency flow or patient behaviour, Kat?
Cracking question. Yeah, I think one of the issues or potential challenges I see with the specification is perhaps the lack of connectivity with primary care. If we're talking about kind of whole system and how we all deliver urgent emergency care, then there's something in there about an equitable assessment process and about reproducibility of that assessment process. I think the way things currently work with primary care being asked to carry on doing what they're doing, however, there aren't enough GPs, and the ask is even bigger than it was last year. And for that to be not joined up in terms of what we're asking 111 to do is an obvious omission, and don't get me wrong, I don't think that it's an easy thing to do, but I think unless that's joined up, then we will continue to have this kind of inequity in the system. So we will not get the correct flows of patients going into urgent emergency care. But it's a great question, one that we could debate for ages.
Yeah,
absolutely. Yeah, thank you, Kat, and I'm sure that we will have future debates within the team around this also. So big thank you, Kat, because I know you haven't been 100% health-wise today, so thank you for joining us and being so engaging and interactive with the crowd. And back to you, Pete.